Now, many of you probably have a gut feeling as to why that is, but I'm going to try to break it down a little bit more clearly. I'm going to try to describe what direct primary care is and how it can save you money. But to begin with, I'd like to start with a question. What should the practice of medicine look like? In the current practice of medicine, unfortunately, doctors are massively overworked. Now, people say, well, why do I care about that? Doctors are high-paid people. But the problem is they have so many patients, 2,500 to 3,500 patients per doctor, that results in long wait times to see them. I just had to update this because I used to quote the statistic from 2014 that the average wait time to see a doctor in the United States was 19 days, a primary care doctor. Well, they just released the updated statistics. Drum roll, it's 24 days now. Since 2014, it's gone up to 30% the wait time to see a doctor. And the sad truth is, if you have a cold or if you're sick, that is just not quality of care. Now, sadly, after all that waiting, you get the great opportunity to wait some more. They've now shown that the individual person, when you come in for one visit, you have to dedicate at least 3 hours of time for that visit. Driving there, waiting in the waiting room. Yep. Anybody here had a wait of an hour in a doctor?
Yes.
Great. Oh, it's only half of you, I would assume. Well, that's almost become a joke now. It's such a common thing. So you're waiting in the waiting room, waiting in the exam room. So sometimes you're lucky, you get out of the waiting room quick, you go to the exam room, but there's another 20 minutes there. There's time. Oh, I'm sorry, am I throwing my hand constantly in front of it? You get to see the doctor, you go to check out, and you drive home. Over 3 hours of time, they did an estimate that costs Americans $52 billion a year in opportunity costs. The value of your time, if you could do something else, maybe be at work, be with your family, gardening, whatever it is that you want to do, that time, there's nothing. If you find out you have a week left to live, there is nothing more precious in your life at that moment than the precious seconds, the time you have. So this is a colossal waste of all of our time. Now, after all of that waiting, you're blessed with short office visits. 3 hours of your time, more than 3 weeks waiting to get in, and you're blessed with 8 minutes of interaction with the doctor. Sadly, that time is usually distracted. It's not even quality. How many of you have experienced this? Hi, you here today? Yeah, okay, what? Oh, okay, yeah. Hold on, let me write that down more. Everybody's turned, that's exactly right. The doctors now, not because they're bad doctors, great doctors, I'm sure, want to do the best, but the mandates and the regulations and the dictates that the doctors must adhere to now mean that they are not focused on you. They have their back to you, and they're focusing on the billing and coding and the documentation that they require to get paid. So this is not even a quality 8 minutes. And I'm sorry to say that it's actually even worse than that. The current system intentionally bakes in conflicts of interest. The doctor doesn't work for you, right? They can actually be paid more to do less for you. And anybody wants more description of that, I'm happy to explain later about how those value metrics and other things that sound really good, pay for performance, well again, sounds wonderful. But how in reality, it's none of those things. It's actually based on payment model and how it actually can be counter to your best interests. So I've never seen a graph that more accurately describes what's happened in the United States than this one. So let me take a quick second to describe it. If you look at this line here down on the bottom, this is the supply of doctors in the United States over a 4-decade period of time. This is from 1970 to about 2010. So in fact, this has probably actually gotten worse than this, but this is a 4-decade period of time. This yellow behemoth here is the number of administrators in the healthcare system. Doctors essentially flat. A veritable explosion of bureaucracy has occurred during that time. And interestingly, again, Obamacare is not even included in this. So my assumption is that it continued to go like this right after this point. The black line is per capita spending in the United States. That's how much each of us spend on healthcare each year. And counter to the political theme that's out there, that doctors are the driver of healthcare costs, what's it tracking with? It's tracking much more closely to the administrative, i.e. bureaucratic burden in the system than it is the supply of doctors. And sadly, what this ends up feeling like is the 800-pound gorilla of what's called the third-party payer system, government and insurance companies, that enters into that exam room, every doctor, every day, every visit, tells that doctor how many patients they can see, what they can talk about. Many times you go in and they start talking about stuff you're not even there for, and what even the treatments can be. Now, I wouldn't bring up a problem unless I thought there was a solution, and part of that solution is direct primary care. And what is direct primary care? Direct primary care is a direct payment model. It's getting back to kind of the way it used to be. The doctor works directly for you. Senator Colbeck was talking about the tiers of separation, and that if you're a third party, low quality, low focus on quality, low focus on cost containment. Well, this is going right back to that one-on-one relationship. You want quality and you want to get something good for what you're paying. And this gets back to that relationship, gets rid of all that yellow that you saw on the other graph that interferes with the cost of healthcare and interferes with the quality. It's usually designed in a low-cost monthly membership model. It's a wrap price. Usually includes all services that that office classically will do. All the visits, all the testing in-house, all the procedures. We couple this to try to save people money with discounted labs, imaging, and medications through in-house pharmacies. So, and we do this also with having reasonable patient loads. Doctors in the United States today, it's very common to have 2,500 to in excess, in some cases, of 3,500 patients per doctor, as I mentioned. Well, in direct primary care, the average is 500 to 700 patients per doctor. What that means is massively improved accessibility. When you're sick, your doctor's there. Where do you want to have reserve capacity in our system? Do you want the ER sitting around waiting for you with crash carts and trauma surgeons to come in and treat you when you have a cold? Or do you want the cheapest place in the medical system to access care, your primary care doctor, and a nurse, just like it used to be in the old days, able to come and see you at a much discounted rate?
All right, yes, that's it.
Thank you. It allows for innovative delivery systems, which I'll get to in a minute. In the current system, doctors are restricted by how they can provide you care by the payment system. There are certain stipulations. They have to be, for example, face-to-face with you for you to be able to access care for them. There's a reason why doctors are very remiss to have a long conversation and actually try to solve problems on a phone call. They're not bad people. I need to stress that. I was one about 2 years ago. I was an insurance-based doctor. But the phone calls in those situations are always designed to drive office visits because that's how they're paid. And if a doctor spends 8 hours on the phone a day, they get compensated zero, they're still paying their staff, they go out of business. So that's the beauty of a membership model, right? If you have a membership model, that doctor's time is already valued. So this allows for innovative ways, using technology and other things, to be able to access your doctor in ways you never could before. It's unencumbered care, appropriate levels of documentation. Most of what the doctor's doing nowadays is documenting not for your benefit, not for the retention of information, which is the historic role of the innovative ways to access your doctor. The historic role of the chart was to store information about you for that doctor's use and to communicate with other practitioners. Well, that's not the case anymore. It's largely a billing and coding sheet. This results in much less strain on the doctor. The doctor now is there just taking care of you, not distracted by all these other things. And again, people go, well, why do I care if I have a burned out doctor? Well, if you have a doctor that runs in and out of the room, doesn't give you much attention, doesn't give you much empathy, you are dealing with a burned out doctor. You don't want that. Good care comes from rested doctors who have your best interest in mind. And when they get to the point they stop caring about themselves, they can't care for other people. It's much less expensive, and it's patient-centered. No matter how much we try to look at altruism and try to be the best people we can be, the simple truth is you do not want to bite the hand that feeds you. And when the doctor works for the government and works for the insurance, though because of their altruism, many doctors are good people, they want to take care of you, don't think for a minute that they aren't foolhardy and going to try to step on the toes of the insurance companies and the government. So what does a membership model look like? In a membership model, it includes all of your office visits, no co-pays. Now, why is this important? It turns out that with minimal increases in co-payments, from $5 to $10, You significantly decrease utilization of primary care doctors. Sounds like a good idea, right? You're going to save money. Unfortunately, it's the classic penny-wise, pound-foolish example of that. You decrease primary care usage, the cheap care. You double hospitalization costs because people delay access to their doctor. They don't come in when things are easy to treat and easy to diagnose. They tend to let it fester. And now, instead of going, I got this discomfort in my chest, maybe I'll go get it checked out and get a stress test through my primary care doctor, they end up in the hospital getting a bypass. And that's not an over-dramatization, it happens. And it includes all in-office diagnostics. So again, rat price, you come in, you need an EKG. Normally they bill at about $50. We have people come in with chest discomfort. Doc, I don't want that EKG, I know it's going to be $50. No, it's not. You're our member, we're going to take care of you. Did you forget your wallet today? Doesn't matter. You're our patient, we're going to do what's appropriate. So we do the spirometry, we do the stress test, the EKG, we do a strep test, we'll do a urinalysis. Anything you would classically do in the doctor's office is in there. And that's great for you, but it's also great for the doctor. Because we're not nickel and diming and worrying about tracking that 10-cent urinalysis. We just do it. It includes all in-office procedures. So we do joint injections, ear lavages, cryotherapy, the things you would classically do in the doctor's office and wrapped in. And then the real innovation in medicine is the telemedicine. Something I like to call virtual home visits, because I think that more characterizes what we're doing. We're using the explosion of technology to give people new ways of accessing us. Phone calls, emails, text messaging. Greg from Senator Colbeck's office called me the other day or contacted me and said, how many patients do you see a day? And I said, it's irrelevant. I said, we could see 10 patients in the office, but I could take care of 20 virtually. So we no longer is that an accurate determinant of how busy that doctor is. So what is telemedicine? Well, let me give you an example. Imagine it's a Saturday morning in the summer, and you wake up, and you've got an itchy rash, and you think, oh man, I was in the garden yesterday, and I saw that poison ivy, but I thought I stayed away from it. Oh man, I know. I'll wait until Monday, and I'll see my insurance company doc. Oh wait, I heard it's 24 days to get in to see them. Oh brother, I'll be lucky if I even get in this week. Oh, this is driving me nuts. Oh, I forget it. I'm just going to go to the ER. Well, in our situation, you forget about that. You pull out your cell phone, right? These got high definition cameras on it. You take a picture. You text it to us. Hey doc, in the garden yesterday, got an itchy rash. Think it could be poison ivy? We text back, usually within minutes. Why yes, that does look like poison ivy. Let me call in some triamcinolone ointment for you. Let me know if you're not feeling better. Quick, easy, convenient, right? It's good for you, it's patient. You got care, you didn't go to the ER, you didn't have to wait for days suffering. You got treatment in the situations when it's available. We don't do things that you can't do on the phone. We don't. If you say, I just cut my finger off, we don't say, well, hold it. I mean, it's got to be realistic. But there are quite a few things that realistically you can do via technology, and this is a classic example. But it's great for you. It's actually great for the doctor. It's good care, right? Got a history in the garden, got a treatment plan, triamcinolone, got an exam, got the picture here, and a follow-up plan. Let me know if you don't feel better. So it's quick, easy, convenience, good care. It's great for you if you're the patient, but I always mention this as though you're the guy with the rash. But what if you're not? What if you're the person who is going to be seen on Monday, and you were just discharged from the hospital with congestive heart failure? And normally in an insurance-based practice, you were going to have an 8 or 9 minute visit. Well, now that doctor is not distracted by the rash that came in the next room. Now they can take the time that they would have allocated to the contact dermatitis, which is a fancy way of saying poison ivy, and they get to spend that extra 10 minutes with you. So now you get to give those people who really need your precious time resource as a doctor, you get to give them more time. And the things you can handle through technology, you can handle easily. It's convenient for you, and it's great for those patients too, recognizing their time resource. So, what does this gotta cost, right? Unlimited visits. Everything we do in the office, all the procedures, all the diagnostics, testing, telemedicine, discounted meds, labs, imaging. Play the prices right, everybody got a guess? How much does that be a month? Starts as low as, you can't say anything, Matt, because I know you know. It starts as low as $39 with my practice. Now, every practice is a little different. Paul probably has vastly better numbers than I do. But they're all in this ballpark. It's all within the extremely reasonable range. Think about what you pay on your cell phone. This is one meal. And I also see people, I saw 2 new patients today, both of them I'm seeing back in 2 weeks. That means in the first month for $39, they got 2 hours of my time. We try to dedicate a lot of time up front. We try to get them straightened away, doing well, and then we do intermittent follow-ups after that to try to keep them healthy. And then of course they come in if they get unlucky to become sick. So people ask, well, how can you do this? Those prices are so low. How can a doctor work for that kind of price? And this is something I like to call DPC math. So these are the ways that we save money. So in an insurance-based practice, when you charge $1, you are lucky if you collect about 60% of that. So that means only 60 cents on that original dollar are you collecting. But the collection of that 60 cents was not free. It eats at least another 40% of that 60 cents off. So that means of the original dollar that you paid towards medical care, only 36 cents actually goes to medical care. Now in a direct approach, we cut out all the middlemen. You charge $1. The collection is at the time of service of those charges. So you have essentially 100% collection rate. So you have about $1 left over from the original dollar charged. But then beyond that, the price of collecting that $1 is the transaction fee of the credit card, which is about 2%. So, of the original $1, you have 98 cents left. That means that essentially three times as much of that money actually goes to medical care. It's much more efficient use of those dollars. We also couple this, as I said, so other savings, opportunity cost. Again, the value of your time. ER access has decreased. My partner recently had a kidney stone. It was before we actually decided to sign up. She decided to sign up for direct care herself. That kidney stone was a $7,000 ER visit. What made her sign up is when I told her, I said, do you realize you could have done direct primary care for 14 years for what that one visit cost you? Because she was in the age range where an annual membership for her is about $500. She could have done 14 years of unlimited primary care for one ER visit prevented. So it doesn't even have to be cheaper in any 1 year. You just have to prevent one ER visit over like a decade to pay for itself. Low-cost labs. Here's an example. I give much more extensive laboratory cost comparisons and more intense lectures if you guys ever want to hear them. But a CBC, you guys know what that is? It's a blood count. White cells, immune cells, hemoglobin, hematocrit, looks for anemia, platelets, they are your clotting time. So that's a pretty impressive blood test. It's got a differential, tells you your various types of white cells, your immune cells. I mean, really a lot of information on that. Bills at $88. Anybody want to guess what we can get them for and charge you the same price for? Anybody want to guess? $3.23. That's what it actually costs to do that test. It's all automated. It's in a machine. It goes right through it. The whole thing is a scam. Low-cost imaging. Now, we all love RMI. We all use their regional medical imaging. Wonderful. They do cash prices. Billed rate, according to healthcosthelper.com, of the MRI in the state of Michigan is about $3,500. 2014, probably worse than this now. RMI does them for as low as $275. We have labs. In the state of Michigan, it is legal with an additional license for a doctor to dispense to their patients only. We are not a general pharmacy, but we can dispense to our patients. So what we do is we go to the same distributors that dispense to places like CVS. We order those labs and we charge them to our patients. We give them to our patients at no increased cost. We give them at our cost. We charge 10% for shipping and handling and the pill bottle and the label maker. And just as an example of that, Crestor, right? This is an expensive drug. I went right before I came here today, I went to Blink Health. They're advertising all over. We negotiate with pharmacies for you. Come to Blink Health. So I went, I wonder what Crestor is there. $77.66. And they say that the price of this was $801. They brag. They say we're like 92% less than the retail value. And I went, well, that's interesting because we're about 92% less than you. So we can get a 3-month supply of Crestor and give it to our patients for $4.23, and that is one example. We do this again and again. Lisinopril is about a penny a pill. So the prices are just incredibly inflated for generic drugs. So to compare the two things, third-party payer system, that's a classic insurance-based model. Doctors are overworked, too many patients, 2,500, 3,500 patients per doctor, you cannot have good access with that. In fact, doctors have to have walls. They have to have barriers between you and the doctor because the doctor can't handle that many. You've got the receptionist, you've got the triage nurse, you call, maybe get called back a couple days later if you get called at all. DPC, historically appropriate numbers of patients, 500 to 700 patients per doctor. Prior to 1980, the average doctor saw about 1,000 patients. Okay, we're less than that. Why? Because we're doing pharmacies and other things to give them. We're doing more services. But that is actually, if you took that out, it would probably be about the same number of patients. So that goes back to the historic norm. What we're doing is not the anomaly. What the third-party system is doing is the anomaly. Far too many patients per doctor. Quality of care just can't stay up when you do that. Distracted. Not only are they really busy, but then they're distracted while doing their work. Focused on billing, coding, and the payment. We're working for you. You don't want us muddling away on unnecessary tasks. If you're going to pay us, you want to pay us to take care of you. I always jokingly tell my patients, you always need to reserve the right to fire me. That's a good stress. Not all stress is bad. As a doctor, that's a use stress. And since I'm not in this area, you always need to reserve the right to fire Paul. Okay? But once you see him, you will never want to fire him because he's good. He works for you. He knows he works for you, so he's going to take good care of you. Conflicts of interest. Again, they're injected intentionally into the system. We can get paid more to do less for you. There's something called high-tech utilization rating. Doctors are rated by how many MRIs they order. That's not a good thing to the insurance industry. You order too many MRIs, irrespective of whether they were the appropriate test to do, they give you a worse high-tech utilization rating, and they ding that doctor's pay, not just for you, but for every single patient they see. So are they disinclined to order MRIs? Oh yes. And then if they go ahead and they order it anyway, you know what? They put barriers to that doctor. Oh, that doctor, they're a good doctor. They're going to do it no matter what the disincentive we give them. Well, now we'll put authorizations in their way. You know, and they try to make it as labyrinthine, Rube Goldberg contractions, making it hard to order these things. Ours, we are your advocate. We work for you. This is a historic role of doctors. We took a Hippocratic oath to our patients. We never did it to the coffers of the insurance companies and the government.
Absolutely.
Access, packed schedules. Again, 2,500, 3,500 patients, packed schedules every day. Direct primary care, same day access. Cost savings, more expensive. The bureaucracy, you guys saw the yellow? The cost track with that. Direct primary care, less expensive. DPC primary care shortage. I'm sorry, I'm getting the hook here. You got people say, well, if you see fewer patients, that's going to worsen the doctor shortage, right? Well, why do we have a doctor shortage? The current system does not incentivize students to become primary care doctors. When primary care is fun again, it's great to take care of my patients, people choose it. It resolves the problem. So to reiterate, direct primary care, the doctor works for the patient. No billing hassles. New ways to access care, telemedicine. Innovative ways to save money. Less bureaucracy, less paperwork, more doctoring. The future with direct primary care. Doctors being doctors.